My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, and I will be guiding you through this briefing today. This is what we're going to talk about. I'm going to tell you a little bit about the organization. Dr. Lynch will talk a little bit about what is hypertrophic cardiomyopathy and why is it so important to learn about. I'll come back and talk to you about the Children's Cardiac Safety Act. We'll be getting a message from our partners at the American Heart Association, and we're going to hear from two patients who we either currently reside in or previously resided in Alabama. And then we're going to come back and talk about a couple of other stories. So who is the HCMA? We're a 501c3 nonprofit. It is the anniversary of our 30th year of service. February 1996 was our founding, and we work to provide information, support, and advocacy to patients, families, and the medical community, as well as the lay public, about HCM and other big heart muscle disorders. We're going to watch a small documentary right now, which will probably give you a really good understanding of why we're here today. Please watch.
I'm Beverly Kidd in the Larkspur neighborhood of Virginia Beach, where a dramatic rescue took place when a child collapsed during PE class here at Larkspur Middle School.
When we got to the hospital, they just showed the thickening of his heart, and then they told me that it was hypertrophic cardiomyopathy. He kept saying he was okay, but something was just off. Like, it just felt like something wasn't right. That moments, I just felt like I had no control over anything. Without our faith, I think we probably would have just fell apart. This is not real. Like, it's no way my mind could not process the fact that he was just here, and now here I am getting things together for a funeral.
As soon as he came home from the hospital, what did he want to do? That's the first thing he said. Dad, when are we going fishing?
It's all personal. I've lost my grandfather, my great aunt, my uncle, my sister, and my dad to HCM. And it tried to get me too. I'm the lucky one, even with losing my best friend, my sister.
I hope you can understand the setup of this story. Those were two stories of young men, one lost to HCM, one almost lost. We don't want to see this happen more. We want to do something to get in front of the diagnosis. So what is the HCMA doing about it? Number one, we have a report card for each state to go in and check to see if the elements of the Children's Cardiac Safety Act are currently law in your state. And if not, we have draft legislation that we can assist you with. We want to improve sports physicals. We want to make one form standard for the state. We want to require certification requirements for those conducting those evaluations. We want it to be in a reasonable time from the start of a sports season. But beyond the athlete, we want to make sure that every child has the opportunity to have a discussion about their family heart health history with the family's chosen healthcare provider. So that is why we want professional development tools to be created. And HCMA is going out for some funding on our own right now. And if we're able to do that, we will be able to provide that service to the states free of charge or with a minimal charge. So we want to make sure that every clinician understands what these diseases are. In the past 5 to 7 years, the diseases that we're talking about have grown in their understanding and their treatments. Some of these diseases didn't have treatments 8 or 10 years ago, when many physicians may have been getting their education in school. So this would be an opportunity to update them. Additionally, the report card will talk about things like preparedness, like proclamations, resolutions, and laws recognizing HCM Awareness Day as the last Wednesday of February every year. Some states do this annually, some do it in perpetuity. We want great AED placement laws for your community. We want to make sure people know how to use those AEDs, and we want to make sure people know how to perform CPR. We want good SAM policies. We want copay accumulator laws in place so patients aren't unnecessarily charged for medications when the insurance company should be paying for it. We're looking at step therapy laws, safe medicine delivery, and non-medical switching laws. Today, we're here to talk to you about the Children's Cardiac Safety Act. But if any of these other issues are important to you or your constituents, please call us and we'll be happy to help you work through those. So look at that, Alabama on the top of the list with an HCMA resolution. So thank you, Alabama, for recognizing HCM Awareness Day. We appreciate your partnership and the opportunity to have conversations with you and your constituents about why heart health history matters. Dr. Michael Lynch is now going to walk us through what HCM is and why we should care about it. Dr. Lynch, the mic is yours.
Thank you. Thanks, Lisa, and thanks to all of you who are joining us today. This is, as Lisa had said, this is a personal issue for a lot more people than maybe you thought there might be with this kind of odd-sounding diagnosis. This has affected me. I'm one of the lucky ones who haven't gone through some of the challenges that Lisa's family has, but it still is something that can be managed and treated much more effectively if you know about it. And especially the big issue is really avoiding children and young adults running into this awful problem. So it's a disease primarily of the heart muscle. Heart muscle grows in an abnormal manner that affects both the function of the heart muscle itself, the shape of it, and then also the electrical impulses that go through the heart. The walls of the ventricle become the high pressure part of the heart become thickened and can block the flow of blood out of the heart, and also affect the way the walls move and get filled with blood. These have a number of different effects, which can be subtle and can be challenging to diagnosis. This is the most common inherited cardiovascular disorder. An incidence of about 1 to 250. And over 1 million people have HCM in the United States, and only about 200,000 of those are currently diagnosed. The risk is significant, and it's not dependent on symptoms in all cases. So symptom-free problems with HCM can be the first indication that something's going on, making primary care diagnosis of this condition so critical. It can also cause heart failure symptoms and stroke at any age. And the good news on this front is that there are ways that this outcome can be delayed or even prevented in some cases. So there are other congenital heart diseases that a number of them cause this thickening of the ventricle in the heart. So the symptoms we just mentioned, the family history is really a key part of this. Heart murmurs are generally, you can find these, but they're not always present either. The history is really the critical thing. A lot of the symptoms that are listed here are ones associated with cardiac failure, but probably the most important one is down at the bottom of no symptoms at all. And that's why this heightened awareness and surveillance are so critical. The complications of this are obviously the big one is sudden cardiac arrest, but other arrhythmias with abnormal heart rhythms and heart block and life-limiting symptoms can be challenging for people at any age. Infections of the heart failure, and even progressing to the need for transplant has been the case for some of us on this call, are a real challenge, and the treatment of HCM is getting better all the time. So there's certainly increased hope and awareness can lead to people having that need for transplant delayed. So there's different kind of life paths that people can go through with this. A sudden cardiac death we've already talked about, but there's treatment for that with an implantable cardiac defibrillator. Heart failure symptoms with medical and surgical management can be, the rate of progression of these conditions can be reduced and the symptoms can be better controlled. And then heart rhythm problems such as atrial fibrillation resulting in a stroke can be managed through blood thinners and also electrical interventions at times. So screening other family members is the critical thing too. Going back to that original heart family history is really a way to help prevent our families from being as significantly affected by this. But
Thank you,
Lexa,
Mike.
back to you.
Thank you. I have to figure out how to use this pin thing now. I have no idea what it's asking me to do. We're going
Your
to
slide
cancel
is
it.
up.
The next slide is up. Okay, so we've changed hands here. Okay, they've made some changes in Zoom this week and they're keeping me on my toes. Sorry about that. So what do we want to do in the state of Alabama? We hope to bring our legislation that we've used in a few other states now and bring it into Alabama. And it will make sure that every well child examination includes a family heart health history questionnaire and the 14-point screening for heart disease as recommended by the American Heart Association for student athletes. Why are we asking for the same screening for non-athletes as we do for student athletes in the heart screening? There is a repository of information on death certificates. This is not happy information we're talking about. Of all of the deaths related to HCM, we know that 80% of children under the age of 24, so I'm using the word children, including college athletics as well here, and college students. So 24 and younger, we know that of those who die every year with HCM on their death certificate, 20% are considered athletes and 80% are not athletes. This is from the Wonder database maintained by the CDC, and we have been tracking this data for over 20 years. We are seeing improvements in outcomes long term, but we know that this is not an athlete's problem, it's a people problem. So the idea of the legislation is to make sure we're asking in every well child examination, what is the family heart health history, and how can we get that person to the next step of the healthcare system? We wish to develop training modules for professionals so we can train them on what these diseases are, as a great deal of knowledge has been ascertained over the past 7 to 10 years. And many clinicians in current practice may have missed this in their education because some of these diseases they just were not understood back then. And we now know these diseases. We want to improve the student athlete pre-participation physical to provide some more education about signs and symptoms that Mike had just discussed. And we want to make sure that the clinicians out there in the communities know these diseases and know how to make those referrals and how to treat. You can learn more with this QR code. So what have we learned? These are the key virtues. No matter what anybody thinks, we are 100% sure that no matter your political affiliation, you have a heart. So this is a bipartisan issue impacting all. We know it is cost effective. It is proactive versus reactive. If we do not identify these people in time, these children in time, we are risking sudden cardiac arrest, and then we're crossing our fingers to hope the emergency response system works well enough and everything aligns so that we can get that child saved. That's too risky. We can get in front of this. We can implant defibrillators when they're needed to be implanted. We can treat with medication, and we can screen the entire family. This limits more costly tests and procedures to those flagged by screening. So if there's no risk, there are no symptoms, and there's no indication for that clinician to refer that person to cardiology, okay. If we're going to do mass screenings of everybody, and we're going to do EKGs and echoes on everybody, that's expensive, that's timely, and we're going to screen a lot of normal people, and we're not going to have time for the people who actually need the care and the assistance. We want to avert much higher cost treatment. If somebody does go down from a cardiac arrest, there is a high likelihood that they are going to encounter a brain injury as well. And we have had many people over the years encounter those brain injuries. One case that I'm thinking of now was a 35-year-old dad who, after his cardiac arrest, turned out to only have a 30-second to 2-minute memory after the event. So he didn't recognize his children, he didn't recognize his family, and he ended up having to go into a home, and that's very expensive. We don't want that kind of outcome for any family. We want to promote pediatric cardiac wellness in general. Our children should be eating well, they should be active, they should know what their heart health history is, and they should know how to keep their hearts healthy. We want to show you that we've proven concept here in New Jersey. I'm going to tell you a little private story on this one. I meant to talk to you a while ago, but I got distracted by my own heart. In 2015, we passed laws in the state of New Jersey, both improving the pre-participation screening physical and the well child examination inclusion. So we've been doing this in New Jersey for about a decade. But shortly after I got these laws passed, I got sick myself and I needed a heart transplant. So I got the transplant, came back to work, and then there was this thing called COVID that happened, and we all got kind of distracted there. And now we are back and focused on this particular language. So the model language has been vetted from the AHA, and you're going to hear from them in just a minute about what they think. We're happy to be partnering with them on this endeavor. We know that we can make a difference if we work with our state legislators to bring this to the attention of clinicians and families throughout your state. So who else is on our side? The American Academy of Pediatrics in July of 21 published an article about sudden death in the young, information for primary care providers. And within this document, they say all children should be screened for the risk of cardiac arrest, regardless of their athletic status. So we are in complete lockstep with AAP's national standing, and we are happy that they published this article. And our thanks to Chris Erickson, Stu Berger, and Rob Campbell, who have been good friends of the HCMA for many, many years. So what are these diseases and how many people actually have it, and why should you care? So the total population of the United States for all of the diseases that could be identified in the type of screening we're suggesting, and these include HCM, ARVC, which is arrhythmogenic right ventricular cardiomyopathy, so the right side of the heart is affected there, dilated cardiomyopathy, Marfan syndrome. This next group of diseases are channelopathy, so there are electrical disturbances in the heart, long QT, short QT, Brugada syndrome, CPVT, anomalous coronary arteries, and congenital defects. Anomalous coronary arteries are the second leading cause of sudden death in young athletes. HCM is the number one. You can't see an anomalous coronary artery with the same screening that you do for HCM. So rather than one test being right for everything, this is why it's important that the clinician understand what the risks are and then refers to the appropriate professional to get the appropriate care. In the adult population and pediatric population, when we look at everybody combined, it's really hard with national numbers to break it down between the two for prevalence. We have about 11 million people in the United States who have these diseases on the top end and about 3.5 million on the bottom end. In Alabama specifically, you have about 158,000 on the top end and 53,000 on the bottom end. We know that we have over 750 families that we're currently working with in Alabama right now. So we are just scratching the tip of the iceberg finding those people because we have another, 50,000 to find at minimum. So we want to find these families before it's too late. This is supposed to get your attention to say, I don't want to read all of that. No, you don't. We don't want to read all of this either. These are all of the headlines from 24 and 25 of young children dropping at the field, young people having cardiac events at school, at play, at malls, at stores. They're out in the community, or they've died in their sleep, or they've been resuscitated. This is too much. It's happening over and over and over again, no matter where you are in the country. So we have the power to make this different. We can stop this. And now we're going to hear from our friends at the American Heart Association.
Hi, everyone. I'm Jeff Reynos, National Vice President for Field Advocacy at the American Heart Association. Thank you to HCMA for inviting the American Heart Association to join you today. We're grateful for your leadership, your partnership, and your shared commitment to protecting students. Every year, school communities are shaken by sudden cardiac events that happen without warning. These moments remind us why this work is so important. Behind every story is a student with dreams, a family that loves them, and a community that wants them safe. Our responsibility is to put strong, science-based safeguards in place before a tragedy occurs, so every young person has the chance to thrive. Our shared goal is simple and urgent. Ensure that students are screened for heart conditions so they can be diagnosed, monitored, and treated as early as possible. Whether a student is an athlete, part of the band, or simply wants to participate fully in school life, they deserve every opportunity to do it safely. The heart is complex, and that's why the American Heart Association promotes a comprehensive, science-based approach to protecting young people. One that spans early detection, smart screening practices, and strong emergency response systems in schools and athletic programs. The AHA recommends a screening approach that starts with the 14-point personal and family history and physical exam, the most effective way to identify students who may require further evaluation. This method is widely supported by cardiology and pediatric experts and is doable in a school or primary care setting. When this evaluation raises concerns, additional testing such as EKGs can be used, but as a follow-up, not as a universal first step. This ensures we avoid unnecessary false positives, unneeded medical costs, and unintended barriers that could sideline students unnecessarily. A science-based screening approach keeps the focus where it belongs, identifying real risks early while making sure the process is fair, practical, and centered on students' well-being. But screening alone isn't enough to protect students. AHA's approach also includes strong emergency action plans, staff trained in high-quality CPR, and reliable access to AEDs on every campus and at every athletic event. These measures save lives and ensure that every young person, not just athletes, is protected. This is where your voice truly matters. Policies change when advocates like you speak up with clarity and purpose. Students should have heart screening available to them, and student athletes should have heart screenings included as part of their annual sports physical. Your stories, your leadership, and your willingness to engage make all the difference in ensuring students receive the early detection and protection they deserve. Thank you again to HCMA for your partnership and leadership. And thank you to all of you for your commitment to protecting students across the country. Together, we can build a future where every young person is safer, more supported, and better protected, both on and off the field.
Thank you, AHA, for contributing that. I am now going to bring to the screen somebody I first met a long time ago, and we've had quite the journey. And now she is on staff at HCMA as one of our nurse navigators. Hannah, tell us your story.
So my story dates back to 2007, whenever my primary care doctor heard a heart murmur. And he sent me to a pediatric cardiologist where I received the diagnosis of hypertrophic cardiomyopathy. My first instinct was, what the heck are you talking about with this $10 word? I have no idea what this is. I've never heard of it. So I immediately went into research mode, even at 14. I soon learned that I would need a defibrillator. And then 3 years later, I would need an open heart procedure or a myectomy. During nursing school, I was leaving clinicals whenever I had my first stroke. And that was caused due to the bottom of my heart not moving. It was akinetic, so blood was pooling and clots were forming. At the age of 23, I had a second stroke. And shortly thereafter, about 2 years later, I received my heart transplant with the help from the HCMA. Because as I was laying in bed recovering from that second stroke, I was thinking to myself, there has to be some sort of a support group for people with HCM. So I got on Facebook, and that's where I found the HCMA. So it's kind of cool how my story has come full circle from being a patient, being helped by the HCM, or by the HCMA, excuse me, to now helping other people navigate through this very deadly disease. I wish that there would have been legislation like this back before I was diagnosed, because had my primary care doctor asked the right questions, he would have known that, my father had heart disease, and then we could have possibly found it even earlier, and maybe I wouldn't have even needed a transplant.
Hannah, thank you so much for sharing your story. You want to give a shout out to your original hometown in Alabama?
Oh, yes. I'm from Tuscaloosa, Roll Tide. So all of my Alabamians, Roll Tide. I might say War Eagle one day, but not today.
Okay, thank you, Hannah. We have another lovely resident of the state of Alabama, Pamela, who has been a volunteer at a few of our events out in the world, trying to help people understand echocardiography better. Pamela, thank you for joining us today. Tell us your story.
Thank you. I'm up here in Decatur, Alabama, and I was officially diagnosed with hypertrophic cardiomyopathy with obstruction last year. I'm now 65 years old. As a child, I was never very active in sports because I would get out of breath easily. And it never occurred to anyone that there might be a medical reason for that. I was slightly overweight, and it was simply assumed that was the cause. This was despite the fact that my father had significant heart disease, 2 heart attacks, a quadruple bypass, and eventually a heart transplant in the 80s. He's since passed away. There was never any discussion that he might have had HCM. Looking back, I can clearly see where I would have benefited from screening earlier in life. Since my diagnosis and genetic testing, all 4 of my children have undergone genetic testing. So far, both of my sons are gene negative. One of my daughters is gene positive at 38, and my other daughter is still pending results. If screening had been available in the 90s when my daughter was active in sports, she might have discovered her heart murmur sooner. That could have led to earlier awareness, not just for her, but for me as well. Instead, I have had to advocate strongly for myself just to receive the correct diagnosis of HCM with obstruction. I'm now being treated at a center of excellence, and that connection matters. Thank you, HCMA, for leading me to a COE. Because of it, if my daughters develop heart issues in the future, they will have a clearer and faster path to proper diagnosis and care. Family screening doesn't just protect one child, it can uncover silent, inherited heart conditions across generations and change outcomes for entire families. Thank you.
Thank you for sharing your point of view, Pamela. And it's fantastic for us to hear that you've used the resources and you've gotten the information for your family. Thank you so much. So as you saw in the beginnings video, there were 2 families featured. One was Derek Armstead. And Derek's story is critical. As you saw, DJ, who was the young man in the original story that you saw, he was the young man who was saved by the AED and CPR and has an ICD today. Derek is the young man that passed away. Here's the critical part. He went to the emergency room approximately 6 days before his death after having an aborted cardiac arrest that was witnessed by his family. When he went to the emergency room, it was August of 2020, COVID times, so things were a little bit different. And they didn't take a family history. They didn't ask him about his family heart health history. They just assumed he had a neurologic faint. It wasn't a neurologic faint. Had they asked him, they would have found out that his mother died before she was 30 years old, waiting on a heart list. The only heart list I know is for a transplant, and his mother never received that transplant. So she did not get her transplant, and her son died approximately the same age as she was. Nobody ever asked about family history because he was a striking, attractive, 28-year-old, appearing healthy young man, but there was something lying beneath. 6 days after he went to the emergency room, he was coming home from being out running errands, brought his son up the stairs in a baby carrier and collapsed and died in the house. And that should never have happened. We could have found out more if somebody in a childhood exam asked him about his family heart health history. It would have been part of his medical record, and they would have been evaluating him for the same disease that his mother had, which turned out to be hypertrophic cardiomyopathy. And we have started a full initiative in his honor and memory called the All Hearts Collaborative. If you'd like more information on that, you're welcome to contact us. If you are a state legislator and you think what we have said has struck a bell and we can do something in Alabama and you want to be our champion or you want to get involved in the cause, Julie Russo is our Director of Legislative Programs. She is here on this call, but she's not on screen with us today. If you'd like to make an appointment, you can scan here and make that appointment. If you are a community member and you're watching this and you want to get involved, there are ways that you can do through our You Join campaign. And that means all you got to do is scan this code and you can send a letter to your elected official that you think this is important and you want them to talk to us and you would like them to move this legislation. So if you are a lawmaker, it's contacting Julie directly. If you are a family patient or just somebody who thinks, hey, this makes sense, use this QR code and you can send a letter. You can even put a video on there and tell your own story to your state legislators, as we've kind of done here today. I would like to take a moment to thank our board of directors and our staff and contractors. We are a mid-sized but mighty team and trying to punch above our weight a little bit here. This is our 30th anniversary, as I mentioned earlier, And none of this would be possible without the support of all of our partners, our volunteers, our emeritus board members as well, our corporate sponsors. But for me personally, none of this would be possible without a donor who gave me a heart. And all I know about my donor is her name was Brandy. Her sister's name is Mandy, and I know she has a daughter. So I am eternally grateful that when it was a time for a family to make a decision, they chose organ donation and allowed Brandy to be my lifesaver. So if there are any questions, we are happy to take them now. I'm going to stop screen share. We're all going to come back onto the screen here. So seeing no questions at this point, I would like to thank you all for joining us today. And if you do have questions after the event, please don't hesitate to call the office or email us. Our contact information is within the materials. Thank you so much. Thank you to our panelists, and have a wonderful day. Bye-bye.